Then
what
you
you're
can
about.
Play.
you can run it from there.
Okay. Good evening, everyone, and welcome to October's Dercum's Disease Answers Roundtable. Tonight on our panel, we have Ray Wood, a patient and advocate, Nikki Johnson, a counselor who is also a Dercum's disease patient, Linda Ann Kahn, who is a lipedema and lymphedema certified therapist and tireless activist. Dr. D'Angelo is also with us this evening, who is also a Dercum's patient. Tonight, we are thrilled to have Dr. Hagerty from Premier Lipedema Clinic with us, and I will let him take it away.
Okay. Well, this is exciting. Let's see if we can get this. Make sure everyone can see my presentation. Let's see. All right. Is everyone able to, let's see, I was hoping that was going to go big screen. Let's see. All right. Can you see the presentation? Does that look okay? All right. Good. Okay. Well, thank you for inviting me. I think this is exciting because I want to talk a little bit about treatments available for Dercum's. I think the last couple of months, to put this in context, for those who may be viewing this at a later time, have been some interesting discussions as we've had other specialists that have come in and talked about different ideas and theories about what may be going on with Dercum's, what the causes are, and I want to talk a little bit about treatments and some of the things that I'm involved with. So just to circle back at the very beginning, Dercum's disease is typically characterized most commonly by these painful nodules or bumps underneath the skin. And this is in the subcutaneous layer. I'm going to talk a little about what that is. Oftentimes it can be symmetrical and is frequently associated with obesity, although not all the time. And then there's a variety of other constitutional symptoms, what we as doctors call constitutional, that just kind of affect overall how people feel, whether it's fatigue, as well as some other things that go along with it, such as depression, anxiety, and even brain fog. And there's a variety of other things that are not necessarily specific to Dercum's, but when you put them all together with these nodules, that yields this constellation of symptoms. Tonight, I want to focus a little bit about these nodules because they are typically the most common thing that are causing problems. And so, as we look at the cause, we'd like to know what the cause of Dercum's is. We just don't know. And it's classified as one of those RAD syndromes or a rare adipose disorder that we just don't know a lot about. And so we wonder if there's a genetic or an inherited component to it. We're not sure, versus just a spontaneous mutation. We think that systemic inflammation plays a role because we're seeing benefits with anti-inflammatory medications that seem to be helpful. And then there's often a component of trauma. So patients will regularly comment that if they sustain overall trauma, then that seems to kind of kick off the event and kick off the disease. So, for example, patients may be fine in their 20s or maybe even in their 30s, and then an event happens. Maybe it's a massive car crash, or in some cases, it could be a systemic illness, a very, very severe lung infection. But that kind of circles back to this systemic inflammation. And for some reason, with Dercum's patients, these traumatic events seem to trigger the body to respond in this way. We don't understand why. And in fact, it will also yield these small lipomas that can grow and cause the problems. Recently, we've had some great speakers on the roundtable. Dr. Herbst, one of the experts in the world and happens to be here in the United States, a few months ago talked about some of her theories about more the microscopic and the cellular or even the subcellular level about potential causes and getting into even the chemical makeup of the fluid that surrounds or bathes all the cells in the human body. In what's called the extracellular space, or milieu is the phrase that doctors will use. Um, this extracellular space, also known as the third space, contains this fluid that is serum that is leaked out of the blood vessels and keeps all of the cells in the body moist. Without that, then the cells very quickly die. And she posits that possibly there's something that's changing in patients with Dercum's disease, possibly even some of the things, some of the proteins such as glycosaminoglycans. That's a big word, and some other proteins that are in there that's changing how the body maintains the fluid that surrounds the cells. And maybe that's contributing to it, but we still don't know. Last month, Dr. Derek, a vascular surgeon and expert, was talking about her experience and some of the thoughts. She made a great example how all roads lead to Rome, and talking about the vasculature and the importance of the capillaries, where the arteries and the veins come together, where a lot of this fluid exchange happens. And that her thoughts that some of that more macroscopic issues may play a role. But again, there's so much that we don't know and so much that we don't understand. But these are some of the leading thoughts. The challenge is that there's nothing that's quite clear. We don't have a specific cause. We can't point to a specific genetic mutation. We can't point to a specific biochemical pathway that's not working. Oh, they're Dercum's patients are deficient in this particular protein, and therefore this enzyme doesn't work. Um, we don't know. And so the challenge is when we look at treatment for patients that are just so uncomfortable or so frustrated and challenged with their condition, how do we treat it? And it's hard because if we don't know the specific cause, then as doctors, how do we fix something if we don't know exactly what the cause is? And so it makes it challenging. And so when we look at treatment paradigms, there's kind of different phases. And I think Dr. D'Angelo alluded to some of these points. Ideally, we'd like to prevent things from happening. We'd like to have a treatment that prevents it from the very beginning. If we know a specific defect in an enzyme pathway, then maybe we can address that, or maybe it's a mineral deficiency, as some medical conditions are. Then you replace the vitamin or the mineral, and the condition gets better. So ideally, we'd like to prevent it from happening to begin with. And so that's where a lot of medicine is going to try and fix that. The problem is with Dercum's, we don't know. Another way of physicians treating patients is reactive. So once something happens, do we have the ability to fix it and shut it down? It requires us that we know pretty detailed what exactly is going on, because then we can tailor the interventions to fix it. And so, for example, you might use like pneumonia. Okay. We'd all prefer to not have pneumonia. And so, in some cases, there are even vaccines that are available for certain types of organisms that cause pneumonia. So that would be preventative. But if we do get pneumonia and we know we're able to figure out the bacterial pathogen that's causing the pneumonia, we can use medications in a reactive approach to treat that condition and make it go away. Um, the last thing is symptomatic treatment, and that's where we don't know what causes it and we're not quite sure how it works, but we still want to try and do something. So let's see if we can just treat the symptoms, and maybe it'll work and maybe it doesn't, or maybe it works really well, or maybe it works not as effective, and maybe it's better for this person and not as effective for this person, but at least it's something. And so the challenge is when it comes to Dercum's, there's so much that we don't know that we're kind of left in this last phase of how medicine works in symptomatic care. Um, and so that's what I want to talk about today and share with you kind of some of the different treatments as we as physicians look at it and say, well, what things do we have to offer for Dercum's patients? So let me talk a little bit briefly about the area of the body that we're talking about when it comes to the lipomas. So if we look at the layers of the human body, and I made an analogy to a sandwich, and if you've been in medicine at all for any length of time, I don't know, maybe it's because it's just so easy for people to relate, but we make a lot of relations to food. So I apologize as you hear my presentation. It's just how we do things. But if we look at the layers of the body, starting with the skin at the very outside and go all the way to the deepest layers of the body, the bones, the farthest inside. So you can see here on this diagram, we've got the skin, and then we've got a layer of tissue, of fatty tissue and connective fibrous tissue, sometimes known as fascia. And then right beneath that is the muscle, and then beneath that is the bone or organs can be underneath there. The area that we're interested in, that I want to talk about, is this layer between the muscle and between the skin, known as the subcutaneous space. There's a few things that are in there. Like I said, there's fascia, there's a lot of fat cells. And remember, fat cells, even though most of us don't like them very much, they serve important functions, right? They cushion the body. They provide insulation. They are a body. They're an energy store, and then they also provide shape to our body. So fat cells provide an important series of functions, but when they go awry is when we tend to struggle with them. So this is the layer that we're interested in, and there's immune cells that are in there to try and help protect us. So this subcutaneous space is an important area. And when we talk about lipomas, this is the area, the space where these lipomas typically reside. And I'm going to go into just briefly, the roots of this. Lip or lipo or lipi is the Latin word for fat. Okay. And when we take the suffix oma, that is the Latin term for a tumor. Now, I want to be careful because sometimes we hear about tumors and we get nervous about cancer. In medicine, a tumor does not mean cancer. A tumor means a mass or a growth. It doesn't some and cancer is obviously a growth, but there are also non-cancerous growths. And a lipoma, for the most part, fits into one of those. And so that's where this term comes from. It literally, a lipoma is literally a fatty tumor or a fatty growth. And almost always, particularly for Dercum's patients, they're non-cancerous. So I want to make that distinction because I don't want people to get concerned or worried that they have cancer when it comes to the lipomas. So we have these fatty tumors, and typically, even patients that don't have Dercum's disease can develop, in rare instances, lipomas. And they're these small, little round, non-tender masses. They're kind of rubbery, and sometimes it can make the skin rise up, and you can see, wow, there's a little bump there. Or sometimes you can't see it underneath the surface of the skin, but the patient can feel it. If they push on their arm or they push on their chest, they can feel this rubbery mass that's underneath there. And for all intents and purposes, it's just a lipoma. It's just a bunch of fat cells that buddied up and got together, and oftentimes there's a capsule in that subcutaneous space. Okay. And so here's an example of that. I showed the diagram of the different layers of the body, and here's where this lipoma typically lives. You can see in that subcutaneous space all those fat cells, and then there's this ball of fat cells that just bundles up together. There's a little capsule around it, and sometimes it can cause a prominence. These are the things that are causing the challenges. So in non-Dercum's patients, these just kind of sit there and we don't really do much with them. They really come to our attention if they're a functional problem. So, for example, they may be small nodules, but they just are just in the wrong space. For example, they might develop in the bra line. And so on a daily basis, that's really frustrating, or in the waistline. And so now you've got this nodule, it's got pressure on it. And so that's one of the reasons that surgeons will take that out. And then there's also cosmetic reasons. It could be in a space or a location that's easily visible and it causes a bulge. And patients are like, man, I'd really like to not have that there. Um, but typically these lipomas are small. And again, here comes the food analogy. Grapes or a plum, or in rare instances, can even get bigger. But typically, these non-Dercum's lipomas, if you go to a surgeon, they'll just numb up the skin and make a little incision, and literally they'll pop out. Like we'll just squeeze at the base, and this capsulated ball of fat cells will just pop out. You kind of have to catch it as you squeeze it out, and you put a couple stitches in, and you're done. Okay. And it's very, very rare that they come back. It's usually kind of a one and done. Now, let's contrast that with Dercum's disease. And so, for the Dercum's patients that are listening, as you know, most of the time these are painful. So, traditional lipomas, patients can push on them all day and they're like, hey, here's this little rubber ball underneath my skin. Not so much with Dercum's. Even the small ones, even if you don't push on them, can be tender and uncomfortable and can cause a variety of symptoms. Dr. D'Angelo, who has an extensive knowledge of this, talked about this and the variety of different types of pain. You can get an achy pain, a dull pain, and sometimes even a sharp or a burning pain with palpation and pressure in a specific area. And so they can be very, very tender, even at small sizes. And in addition, not only can we have this ball of fatty tissue, but sometimes we can get little blood vessels that grow in there. And so you'll hear us use a phrase called angiolipoma, angio meaning blood vessels that are just kind of mixed together. Um, when we look at Dercum's nodules, they usually kind of start out poorly developed. And as I've ultrasounded these, sometimes it's hard to even find them, and I'll put the ultrasound probe over the patient's skin, and the patient's like, it's right there. Every time I put the probe over it, I'm not even really pushing very hard, but it's really tender. And I'll look up the screen, and sometimes it's hard to even see. It just looks like regular fatty tissue. But then over time, oftentimes these start to mature and they develop this capsule, and then that can be seen on ultrasound, and then it's very clear and distinct. And the challenge is so that over time, as these progress, then that capsule can get thicker. And I call it the three T's. It gets thick and tough. And then we're finding it can also get tethered. And I'll share an example of that. But that capsule, I think, plays a role when we look at it from a clinical side. How do we treat these? How do we make them less painful, or how do we make them go away? Because that's ultimately what patients want. And that capsule can play a role. The challenge is that experience in the literature generally will quote a round number around 50%. 50%. If we try and get rid of these, traditionally it's been by cutting them out, whether they're small or large, then 50% of them can recur. And not only can they recur in that site, but then sometimes with trauma, a patient may bump into the corner of a table, and then a couple of weeks later, they'll develop a new one, again, where that traumatic injury was. And so, whereas with patients that don't have Dercums, they bump into a table and they don't get these lipomas. The other challenge with this is that they can vary in sizes. So it can be very common that you have these small little lipomas the size of peas, but they can become grapes or plums or, goodness, even the size of a clementine or a small mandarin orange. And so, depending on what kind of interventions have been tried, or even trauma seems to associate with the size of these lipomas. Um, And so, again, these are traditionally not cancerous, but the bigger they are, then they can often become more tender. And then as they take up more space, then it can also become more problematic with clothing or activities. And then it really impacts quality of life. I talk a little about the membrane, and initially, when I first started learning about this, I didn't think that was a big deal. But the more that I get involved in the treatment, this membrane kind of plays a role. The smaller the smaller lipomas, sometimes I can't even find a membrane. I'll look with ultrasound and I can't even see it. It's so imperceptibly thin, almost like the membrane of an egg yolk. But then as the lipomas grow over time, then those membranes get thicker. Some of the larger ones can have quite a thick membrane that's very firm and hard to work with. And typically what we're finding is as they get larger and they get that thicker membrane, they start to develop these little branches that stick out, a tethering mechanism. And that becomes problematic because if you have a lipoma that's in that subcutaneous space, in that sandwich area, and it's sending a tether down, it can go down to the surface of the muscle. There's a fascia, a connective tissue on top of the muscle called the epimysium that keeps the muscle as one specific whole. And in some cases, we're finding that tether can go down and attach itself literally onto the muscle or go sideways into other objects. And that becomes an issue if we want to cut that out. How do we get these tethers out? And maybe is that the cause of some of this recurrence? And so that thickened capsule again can develop these tethers that come out to the side or below it. The current treatments available for the lipomas, okay, are somewhat limited. Again, we're getting back to symptomatic because we don't know how to stop these from happening or prevent them. Some patients will say, "Man, every time I have a significant trauma, I bump into something. Then, a while later, I develop a lipoma there." And it's like, well, are we going to bubble wrap the patient for the rest of their life? That's not a great way to live the rest of your life. So it'd be nice to, again, figure out how to prevent them. We're not there yet. So how do we treat them once we're there? So there are topical ointments that are available, and even patches that have been used with limited success. Again, some of these lipomas tend to respond, but then you have to keep applying them on a daily basis, and maybe the amount of medicine goes up. And then other lipomas in other areas don't respond to the topical ones. And so then we can try systemic medication, systemic NSAIDs, such as an ibuprofen or another anti-inflammatory medication. And in some cases, sometimes the pain's bad enough that it needs narcotics. And again, a lot of patients, understandably, don't want to live the rest of their life in narcotics and in that haze, as well as the stigma that goes along with it. So it's understandable to say, man, I don't want to go there, but these are really tender. We've tried a variety of medications in the House of Medicine to inject to see if we can put these medicines in here to make these things go away. And steroids is a known one that has had some limited success. But again, we see recurrence of these lipomas, and so it makes people hesitate whether or not they should use them. So we get mixed effectiveness. Another option for getting rid of these lipomas is excision, which basically means make a cut on the surface of the skin and just take it out. And so the challenge is that it can be sore for a little bit afterwards. And again, some of these lipomas tend to come back because we're causing a little bit of trauma in the process of cutting this out. And so then is the process of removing one causing enough trauma to make another one grow up? Not all the time, but patients have mentioned that. And I've seen patients that say, yeah, right next door, a couple months later, I got another one. And so then it's disheartening and frustrating, totally understandable. But again, this is just one tool, one of the few tools that we have. And so as we look at the size of these lipomas, you sit there and say, well, if you have all of these pea-sized lipomas and maybe there's 40 of them, well, so are you going to go to the doctor and they're going to numb up all 40 of these tiny little lipomas and make an incision and pop them out? That may not be worth it. Okay, especially with the trauma. But then maybe some of the bigger ones, the grape sized ones, you're like, oh, okay, this one's really causing a lot of pain. This one's just in a really weird spot. So let's cut that one out. Okay, all right, that might be helpful. And then again, if they're even larger, like plum size, it may be to that point where it's like, okay, we got to be done with this. We got to get this out. And so this is what's been around in medicine for 40, 50, 60 years is to just excise it. The problem is the bigger they get, the bigger the incision to get that out. And again, if there's a tether, if it's going down into the muscle, then trying to get that lipoma out can sometimes cause some injury or inflammation to the muscle that's underneath or tissue around it. I've had some patients report that they've seen the surgeons gone in and they literally have pulled the lipoma out and there's this tail and they have to keep making the skin incision longer so they can find the end of that tail and get that whole thing out. And it's hard to know and it's hard to treat. One of the other possibilities is what's called Taylor's therapeutic lipedema reduction surgery. It's basically a specialized form of liposuction. Um, and so basically, if you have small lipomas, then a hollow tube is put in underneath the skin. And after numbing up that fatty tissue, then we're able to suck out these small fatty or medium sized fatty lipomas. Not all liposuction equipment is effective for this. Some of the other ones that use laser or ultrasound can cause more trauma and cause more lipomas. But the water assisted liposuction or the power assisted liposuction is minimally invasive and has been able to do that. Now, the interesting thing is I treat a lot of patients with lipedema, and many lipedema patients have small nodules. So it begs the question, and we need to get Dr. Herbst to speak up. Is there an overlap between lipedema patients and Dercum's patients? Because they all have these nodules in common. But my experience has been that with these smaller nodules, I'm able to get them out successfully. The challenge with the liposuction is we're generally treating a larger area. So there's more downtime after the procedure for a week, as well as the cost of the larger procedure. But it can be effective for some of these smaller lipomas. And my experience is most of the time they go away unless there is more focal trauma. And that's where it can recur. Um, Now, the challenge is with the larger lipomas, some of the patients say, I don't want to have this surgically cut out. Can you go in with the liposuction and do that? And I've actually had a couple of patients and we've talked about it and I've talked about the risks and benefits and said, there's a big capsule there and it could grow back. But I treated a patient 2 years ago, and she had some larger lipomas, and so we treated him, and her pain went down, and most of the lipomas stayed away for now. But after the procedure, I felt like a little depression underneath the skin afterwards, and to me, in my mind, it felt like a crater or a shell, almost like I had taken the lipoma out, but part of the fibrous capsule was still sitting there underneath, but the bulge and most of the pain was gone. And so, was that successful? Was that effective? Well, for the patient, a lot of these bulges on her arms were gone and much of her pain was gone and she was able to come down off of a lot of her pain medications even though there was still a little bit of some cosmetic issues afterwards. So for her, it sounds like that was helpful. and time will tell to see if these recur. So I get a little nervous about the larger ones, whether or not that's actually going to be effective. So this specialized liposuction can be helpful. In fact, you can probably go online. There's a surgeon that a few years ago in Southern California that was illustrating how he can get these lipomas out. And he would perform liposuction and then make the incision a little bit bigger in the skin. And then he would take the tube and he would literally squeeze underneath the skin, and these lipomas would literally pop out. He was videotaping it and he would just collect them. And he was able to get them out, the size of a grape or a kidney bean. And so again, just illustrates another way to get rid of the lipomas, but it involves a larger surface area. So that's one particular way. So we have surgery to just cut it open, and we have this liposuction. The question is, are there other options? And this is where I'm going to spend the rest of my time here, is talk about focal lipoma treatment. The question is, can we come up with a way to improve and treat the lipomas with injection therapy? Um, and the goal is to shrink the lipoma or make it go away. And the goal is to reduce or hopefully, possibly even eliminate the pain of the lipoma without a lot of downtime and technique. Because most physicians have been trained on doing injections. So that's a skill, technique that most doctors, at least in the United States, have the ability to do. So if we could come up with a medication that a doctor could inject into the lipoma and treat the lipoma, this sounds like a win, rather than having to cut things open or do this extensive liposuction. And especially if injecting the medicine can do multiple of those goals. And so that's where some of these clinical trials are coming into play. And so the clinical trial that I'm part of is designed to answer that question, to say, they've come up with a medication, and by injecting it, can we reduce the pain? Can we reduce the size of the lipoma and make the patient's quality of life better? And then wait for a little bit and watch to see, does it come back? So the phase two is significant. I just want to review this briefly. The FDA requires pretty extensive testing before they'll give a stamp of approval and allow doctors to prescribe medications and use treatments. And so you'll hear these terms. The preclinical phase is basically answering the question, does this medicine even have a hope? Does it even work? And so they'll try it on petri dishes and cell cultures, and then even sometimes small animals or tissues from animals to see and say, wow, when I use this on fatty tissue, the fatty tissue undergoes what's called apoptosis. It dies, and nothing else around it dies. So if that seems to work, then they run all these tests to see, all right, we're not causing any other side effects. So then phase one is, if they get approval, to use it in humans in just a handful of patients, to say, okay, we don't want to release this to everybody, but we need to test it and make sure, does it actually work and is it safe? And so they do a couple on a handful of patients, and are there side effects? And if that goes well, then they go to phase two and they say, okay, well, it appears to be safe. Does it actually work? Does it actually do what you think it's going to do? And so they allow us to do it in a few more patients. And if that works in phase two, then it goes to phase three and they say, okay, well, let's prove it that it wasn't a fluke. We're going to do it in a lot more patients, and we're going to make you monitor it. And then we're going to compare to other treatments to see, does it actually work at a bigger scale? And if it does, then the companies take all of that evidence and go to the FDA and say, we want to do this new medication. And if the science is valid and the numbers are valid, then they'll approve it. And then even after it's approved, they require the companies for a couple of years to monitor to make sure as it gets used more and more and more to make sure that there aren't any new things to develop. So there's a very rigid process. And so when I talk about phase 2 trials, you can see we're kind of at the medium phase where we're starting to increase the number of patients to say, does this actually work? And this is a medication that goes under the name, the number CBL 514. And it's actually a combination of two existing medications. So these weren't made up. And actually, you may recognize some of them. One of them is curcumin, which is the active ingredient in turmeric. A lot of people are taking turmeric because it's an anti inflammatory, it's an antioxidant. And then the other medication is transresveratrol, hard to get out. Another plant-based antioxidant. It's in the it's in the capsule, the membranes of grapes and blueberries. And so these are substances that are you can buy them online. And they're available. But what they have found is that when you put those together at specific concentrations, that we seem to get a synergistic effect, and it seems to have an effect on fat cells. And it causes a process called apoptosis. Apoptosis is the term for programmed cell death. And so basically it tells those cells it's time for you to go away. But it doesn't damage we think it doesn't damage anything else. And so again, the sponsor has gone through lots of laboratory tests. They've looked at dosing amounts, concentrations, the frequency, the side effect. And as they did this preclinical testing, it started to show benefit. And so they said, all right, let's apply for more studies. And so they did initial studies under a doctor, and they did a couple of tests and treatments, and they looked at the size of the lipomas and the pain, and they saw improvements. And so they went back to the FDA and said, okay, here's our results. Can we do more studies? And that is where we are today. And what I'm participating in is this study. Now, there's different ways to evaluate this, and what we're doing is what's called a placebo-controlled, single-blinded, randomized study. And so these are all important things that help us really nail down scientifically what's going on. So we talk about placebo-controlled. What we're doing is half of the patients are going to get the medicine, half of the patients are going to get saline, water. Because scientifically, we're trying to answer the question, does just the process of sticking a needle in the lipoma and putting some liquid in there, does that cause problems, or does that cause the lipoma to go away? And the only way to answer that question is to just inject saline. And so the patients know this when they enroll in the trial. We tell them 50-50 odds. The computer's going to pick. We don't, I as the doctor don't get to pick. We put in the information and the computer just says this person gets randomized to either placebo or the medication. And then when we do the actual injections, we make the patients wear a blindfold. So we hide it to them so they can't see, and they still have no idea whether or not they're getting water or they're getting the medicine. Because what we're trying to assess is, as the patients go through this process, are they actually feeling better? Or do they just think that they're feeling better? Not that they're trying to lie. Nobody's trying to lie. It's just part of the process. And so by being a single blinded study, so I know what's going on, but the patient doesn't, then the patient just says, that one doesn't feel any better. A month later, doesn't feel any better. Okay, we write that down. Or a month later, oh man, this one feels a lot better. Okay, we'll write that down, and then we compare to see who got what later on. Now, we're also doing this study by using ultrasound guidance. So I use an ultrasound machine and I find the lipomas, and then literally with the ultrasound machine on, I numb up the skin and I put the needle in underneath the skin, and I literally watch the needle go into the lipoma because we want to be absolutely certain. You'd think you could stick a needle, if the patient's got a lipoma and they've got a bulge, I'll stick a needle in it and inject it. We want to be absolutely sure. And so I'm required to have the ultrasound there and literally watch the needle go in and literally watch the substance be injected into the lipoma to prove that we're putting it in the right spot. And that way we can test again, does the medicine actually work? And so the patients at this phase are getting 5 different treatments over the course of 6 months. And then 2 months after that, they come back and we take measurements and we see how their pain's doing, again, to assess, is this being effective? And so this study is going on right now as we speak. It's been going on for months, and we are almost at our maximum enrollment. So those of you that were interested, we've just about reached our enrollment, and because the drug company has said, all right, here's how many patients we need, and we're almost there. So, but the good news is that as we have finished our enrollment, as we treat all these patients, we're going to follow them for 6 months, and then hopefully gather results and process it. So it's pretty exciting. So I've been talking for a while. Let me put all this together. I put up this picture of a silver bullet. Is this medicine a silver bullet for Dercum's disease? Silver bullet meaning just the one perfect thing that targets it and takes it out. Um, I think that would be nice. But between you and me, I'm not sure that that's the case. That doesn't mean that the drug is or isn't working. It's just there's so many variables with Dercum's disease. Small lipomas can be a little different than medium, than large, like we've talked about. Whether or not there's a tether, whether or not there's a thick capsule. And so there's all these variables. And so as Dercum's patients probably sit back and say, okay, Dr. Dan, so what's the right answer? I'm tired of being in pain. What's the best treatment for me? And again, that's why I say I don't know that there's a silver bullet today. Um, and so I think what needs to happen is that the Dercum's patient needs to have a specific conversation with a doctor that has knowledge about Dercum's, and so you can match the best treatment for the best situations. So, for example, if you have tiny pea-sized lipomas, okay, surgically cutting them out may not be the right answer. And maybe some of the topical stuff or the systemic anti-inflammatories. Dr. D'Angelo talked about some of the new GLP-1s. We know that there's significant anti-inflammatory properties and benefits to those medications. And can that really help with the Dercum's patients? I think some patients are seeing some benefits, and maybe that would be helpful. But some of the medium lipomas that are in particularly sensitive spaces, maybe those need to be cut out. Or maybe there's so many of them that that specialized liposuction would just be best because there's a whole bunch of them in a limb, and just get them all out at once and be done with it. Again, that would require customized treatment versus you have the larger ones that oftentimes are tethered, and even the liposuction, it's hard to get those out. So then maybe doing a definitive surgery route would be the best way. So I think it requires individualized, customized treatment. What I hope you'll take away from this is that actually I think this is really, really cool. We're still trying to figure out whether this medicine that we're injecting is going to work. But there's two takeaways. Number one, if it's effective, then it's adding one more tool to the physician's tool belt to provide you treatment. How exciting that is, because this is a rare adipose disorder and there's just not a lot of time and money. We hear that almost on a monthly basis in the roundtable. Not a lot of time and money being invested into this disease. And so the treatment options are limited. But here we potentially might have another one, and it's minimally invasive, and its cost might be not out of the moon. We don't know. But the second thing that I think is exciting is check this out. There's a pharmaceutical company that has said, hey, here's a medical condition we're interested and willing to put some research dollars behind. I think that's exciting because somebody's paying attention and somebody's willing to put some money into this to try and find potential more tools and potential treatments to help Dercum's patients. So when it comes to this injectable, the jury is still out. We're still in the middle of the trial. But again, I think it's exciting because it potentially could be another option. And it means more people are becoming aware of the condition. So I think these are exciting times. And I hope that's been insightful for you. So hopefully I'll use a few minutes for questions. Lauren, what do you think?
I think that we should turn it over to the panelists first, because I know that everybody is dying to ask you questions, but great presentation. I think that you
Yeah,
should be like a narrator with like a voiceover or something. Incredible, incredible.
Thank you.
But to the panelists.
I have a question. I remember when there was the trial several years ago, and they were actually injecting into each lipoma. And I had sent several patients to Dr. Herbst at the time, and she couldn't work with about 5 of them because the lipomas were clustered. Is there any such criteria in this particular study?
There is, because what we're trying to answer, what we're concerned about, if they're clustered together, then they may be communicating. And so the lipomas actually may be linked to each other. And so, from a patient's point of view, you might get excited and say, well, if you inject one and then the medicine goes everywhere, just get them all out. But as a scientist, what would happen is if we inject it in the one lipoma and it spreads into the others, it dilutes the medicine.
Ah,
And so then if it dilutes the medicine and it doesn't work, then did it not work because the medicine just doesn't work? Or did it not work because it got diluted?
mhm.
And so to protect against that, we need to find isolated lipomas so that we don't worry about the dilution and we say, okay, we worked really hard to get the concentration. We think this concentration works. We're going to put it here and nothing else is going to bother it. And it either works or it doesn't. And so, yeah, those same restrictions are in effect for good reason.
Understand. Thank you.
I'd like
I
to.
have a question. Just
Okay.
one. Um, have you done just subdural ones? And have you done any in the muscle for the injectable?
We are staying out of the muscle at this particular time. And so everything is in the subcutaneous space. So beneath the epidermis, in the dermis, subdermis, all the way down up until the muscle. So that whole the meat of the sandwich, proverbially to say, yeah.
Thank you.
Uh, can I go now? This is Ray. I, Hi, Dr. Dan. Wow. I mean, I swear my mouth was agape the whole time. I really, I am so dramatically impressed by, it may not seem like much, but the information you gave us today is really crucial. But
Good.
I won't go on and on. I'd like to ask you something that is a little off track, but maybe not. I hear more and more science talking about using ultrasound to guide to lipomas. doesn't it? It seems to me that we also may be developing a way via ultrasound to repeatedly diagnose Dercum's disease. I,
Yes.
I have been thinking, and it may be wrong of me, but I mean, there's got to be a way we can develop a repeatable process for identifying Dercum's.
So ultrasound is a very effective tool at characterizing and diagnosing a lipoma. Okay. The problem is not all lipomas are Dercum's lipomas, or not all patients that have lipomas have
Yeah,
Dercum's disease. In fact, it's probably the converse is true. The vast majority of patients that have lipomas, and usually it's just one or two, don't
yeah,
have Dercum's disease, right?
yeah, that
So
makes
there's
sense.
something else that makes Dercum's unique. And it gets back to the constellation of symptoms with the constitutional symptoms, the generalized weakness, the malaise, the brain fog, and stuff like that. But also, I think the pain with the lipomas. So I think ultrasound can be helpful as a diagnostic aid, but I think we need a little bit more diagnostic clarity as to very specific things that formally diagnose Dercum's and nothing else. And right
Yeah,
now,
that's
I'm not sure that exists. It's more of
yeah,
just, like I said, a constellation of things and a physician that has experience in that saying, yes, that fits versus no, you just have a few isolated lipomas. I've
thank you.
used ultrasound in my practice for over 20 years, and I think it's a powerful tool and can certainly be helpful. Um,
Thank you very much.
yeah, good question.
I have a question. Sorry.
Yes.
When you were talking about the WAL, the PAL liposuction technique to remove lipomas,
Yeah.
were you doing that specifically and directionally for lipoma, or is that a generalized liposuction that happens to get the lipomas? And are tails a problem when you're doing that?
And what was the last one? Our what?
The tails,
The tails.
yeah.
Yeah. So the liposuction that I perform is specialized for lipedema, so it's lymphatic sparing, and so that's why the other types of liposuction don't work. And then there's a specific technique. Um, it was not initially developed specifically to go over the lipo to address the lipomas, but instead to address the lipedema itself.
Okay.
But many, I would say 40 to 50% of lipedema patients also have nodules. And the smaller ones, this particular liposuction treats phenomenally, has been my experience. When I have patients that truly have Dercums and um, and we have those larger lipomas. Those are hard. In fact, it was it was technically challenging. I remember doing the procedure and working hard to try and reduce that lipoma. And again, I was left with like it felt to me kind of like a divot, like a like you were golfing and you took a little divot out of the grass. And so afterwards, I was like, oh, did I did I did I help the patient? But the big ball was gone. And so I was like, well, I got rid of the big thing. And so I've watched her over the last 2 years and so far it hasn't come back. And again, her pain feels better. So that's literally just from my personal experience. But I've talked with other surgeons who have literally gone into the operating room and made big incisions and literally are just trying to tease this. They'll try and pull on this lipoma and it's literally lifting the muscle up with it. And they've got to separate the lipoma from the muscle. and find that tail. And so I think that's where, in some cases, actual resection might be better, because maybe that tail is a nidus for the lipoma to come back. I don't know. There's just so much we don't know, but that's just my brain thinking it through.
Okay, thank you.
Yep.
Thank you, Dr. Dan. This is really incredible, super helpful. It's amazing to see actual studies being done on this.
Yeah.
And it really speaks to the care with which you designed the study as well, with which you're going around it. We have a saying in the laboratory, slow is smooth and smooth is fast. And I think the more careful we can be with these types of studies, the sooner we'll come to answers, even if it can seem frustrating in the moment. So just really thank you. But I also, my research and my work is all in cancer biology, and there's so many aspects of this disease and these tumors that are so different from normal lipomas, and are really, intriguing from, a molecular and a physiological level. When kind of one of the things that interests me the most is the concept of recurrence, because normal lipomas don't recur. There's not a thing that's known to happen. When Dercum's disease lipomas recur, and I know from my experience, as well as multiple other people I've talked to, I've had tumors grow back in the same exact spot they were removed. Does that to you suggest that maybe they're growing back from some cells that were missed? Is there evidence of metastatic disease at any point? Is kind of all fat primed to form tumors? Kind of what are your ideas, kind of going around that?
Yeah, I haven't seen any evidence of metastatic disease. And as I've talked to a few other surgeons that have surgically resected them, in what's called en bloc, as just a mass, and then we send those to PATH, and we call slice and dice them. They bread loaf them and look at them underneath a microscope. We're not seeing metastatic disease. We're just seeing a lot of just disorganized um, adipocytes with, sometimes vascular cells and then some immune cells. Um, so, the recurrence, that's where, as I think about the capsule and I think about the tether, in my mind, that's why I'm like, well, I wonder if that's causing that recurrence. Because conceptually, I used images of, like, a small mandarin orange, and so you pick up a mandarin orange and you'd think, if you pick it up off of the table, there's nothing left on the table, right? Because the orange is just so fully encapsulated and it's completely smooth. But in practice, as we try and pull these tissues out, we can't always be sure, and that's with cancer biology, we can't always be sure there's not just this tiny little piece that got left in there. And it could be one cell, right? Especially, in cancer biology, one cancer cell is just enough for that to blow up. And that's why oftentimes you have surgical resection followed by chemo to try and clean up whatever got left. Not that the surgeon intended to do it, it's just they're microscopic. These cells are microns in diameter. And so, to get to your question, in my mind, is that the case? Then I think that's probably the case. But then it begs the question, what's fueling that, right? Like, we just got rid of it. Is there so much inflammation there that it's just fueling those cells that are left for them to grow back? Or was there just coincidental repeat trauma that was there? You bumped the corner of a table and there it goes, and that just damaged those cells enough to cause them to act that way. I don't know. I haven't seen a recurrent trend that I can put my finger on, to identify that. But I think those are all valid hypotheses.
All right, we have 2 minutes left. We're going to try to get to Juanita and a couple of questions from the audience.
Okay, So Nicole is asking you, Dr. Hagerty, if you know of anybody near Spokane. Spokane? I don't know how to say it. Spokane.
Spokane.
That can treat mast cell, that can diagnose it. Because a lot of us have mast cell, lipedema, and Dercums, and so she's wanting help to actually get treatment for mast cell, not diagnosis.
So for MCAS, I am not familiar with anyone. That doesn't mean that there isn't. I'm not familiar with anyone that does MCAS. Because there's so much overlap with lipedema, Dercum's the rare post disease, and MCAS and some of these others, then I have more familiarity and experience with it. I think I can help. But I don't have anyone in particular I can put my finger on.
Thank you. Amelia wants to know, are there any doctors in South Florida that can do the TLRS surgery?
Yes. Let's see. There is a doctor by the name of Thomas Su, S-U, that is, I think he's in the greater Miami metro area that uses power-assisted liposuction and can do the Taylor's surgery. I think there's another one, but I can't remember the name off the top of my head. Sorry.
Oh, no problem. And I'll make sure I've copied and pasted all of these to you guys. If we don't answer, we'll try to get it back into our group and try to get some of this answered for you guys. Because we are at 9.
We
Does
are
anybody?
time.
You did? I see. She cuts us off. I knew it was coming.
It went fast, or I talked slow. I don't know.
No, you just had a lot of information to get in there, and it was wonderful. But
Yeah, it really was.
it's time.
Okay.
Thank you so much.
Well, thank you for the invitation. It was nice to be with you all and spend some time with you, and wish you all the best.
Thank you so
Dr.
much.
Hagerty.
Bye-bye.
Good
Take
night,
care.
everybody.
Thank
Good
you.
night.
Night.
Bye.
So much. That was wonderful.
Thank you.